everyone. This is a quick review of a very important topic for exams, male infertility scenarios for your MRCG Part 1 as well as Part 2 exam, particularly Part 2 exam where EMQs are the most scariest part. And these are the keywords which are going to help you in answering your EMQs related to male infertility. And we all know that male infertility is a very favorite topic of RCG. So how important it's going to be, you all know about it. So let's start the scenario. So first thing, whenever you have a male infertility question, you have semen analysis, right? So you have a semen analysis report in front of you. When you have a semen analysis report in front of you, now you look at the report, okay? You see that there is something abnormal. So the most important thing is you have to look at whether this is a single report or there are two reports. If it is a single report, then no doubt, whatever the report shows, your next answer is going to be, your exam answer is going to be repeat semen analysis. Because without two reports of semen analysis, you cannot make any diagnosis. So with just one report, don't label patient as oligozoospermia, azoospermia, or anything like that. You need repeat semen analysis. Now, the second important thing which is asked in exam is when to do repeat semen analysis, right? So, right away you have to repeat or you will wait for 3 months. There are two types of scenarios. So, for this, we divide the count, divide this according to the semen, the sperm count in the semen. So, if it is less than 5 million per ml, right? If the concentration is less than 5 million per ml or there is azoospermia, then that is a severe oligozoospermia or azoospermia. And the other category is where you have 5 million to 15 million sperms per ml, right? So now this category where you have 5 million to 15 million, you will wait for 3 months. So your answer will be repeat semen analysis in 3 months. If it is less than 5 million or it is oligos or azoospermia, absent sperms, in that case, it's going to be repeat immediately, right? So first answer, repeat semen analysis. Then you have to look whether you have to do it 3 months or you have to do it immediately, right? Now this is the answer. Now what happens? The next thing is what would be the management step? So of course we will be talking of further investigations in next slides. But usually when you have oligozoospermia or azoospermia, you have two types of answers in your exam, IVF and ICSI. Okay, so when to choose IVF and when to choose ICSI. Again, we will use the same two categories. When it is between 5 million to 15, less than 15 million, then we have to choose IVF. But if it is severe oligozoospermia and azoospermia, we have to choose ICSI, right? So here it is about ICSI and IVF. Now, what is the role of testicular biopsy? When it is the answer, when we have to answer testicular biopsy, so whenever we have severe oligozoospermia, like less than 2 million counts, or it is absent azoospermia, then it is always advisable to do the testicular biopsy and see the seminiferous tubules and the maturity of the sperms. And you take out the sperms and see that what is the, do you really have a healthy sperms for the ICSI? Particularly in cases where the semen is showing azoospermia, you can retrieve the sperms from the testes and use it for ICSI. So therefore, the correct answer will be, if you are looking at those cases, less than 2 million count or oligozoospermia, and your question is asking next appropriate step, keep your eyes open and watch for testicular biopsy. If there is a testicular biopsy, yes, you would like to do the testicular biopsy and followed by ICSI, right? So this is how, see, in EMQs, the answers are very close to each other. Like if you have testicular biopsy, ICSI, you will be confused what to choose. So you have to see next appropriate step is testicular biopsy, and the most appropriate will be ICSI, right? So this way you can answer your questions about the low sperm count. Now the next thing, whenever you have any issues in the semen analysis, you go for hormones, right? So now in some questions, some scenarios, you have questions about the hormone levels like FSH and testosterone. Now, if your FSH and testosterone both are low, means the problem is at the level of hypothalamus or pituitary, right? So gonadotropins are not there, and so testosterone secretion is low. So what would be the management option here? Yes, you guessed it right. It's going to be gonadotropins. Another scenario could be where your FSH is low, but testosterone is high. So what could be the possible scenario here? So either there are some tumors which are producing testosterone more and therefore the levels are high, but usually they are not so much high with the given exam. They give it like almost normal towards the higher side. So what it could be? It is a very favorite scenario of RCOG, anabolic steroids. A person on anabolic steroids, he has a well testosteronoid levels and a good body, which is correlating with the good testosterone levels, but FSH is low because you are providing testosterone from outside, and that is decreasing the FSH levels by the feedback. So anabolic steroids, very, very favorite scenario of RCOG. You have to stop anabolic steroids and repeat the semen analysis at least 3 months after that. And if it is getting better, then you can still wait and then repeat again after 3 months. Another important scenario which comes in exam is mild male factor infertility. So mild male factor infertility, what to do in that? So there is no role of any IUI in this. Directly you have to go for IVF, right? So no role of IUI in mild male factor infertility. You can do directly IVF. Another scenario, another very important keyword, loss of libido. So what does this indicate? Whenever there is a word mentioned in loss of libido, think about prolactin levels. It's going to be a prolactin scenario. So hyperprolactinemia, and here will be your correct answer. I hope this information helps you in answering your EMQs. For all your questions, try fix your keywords, your rules, and answer accordingly. So this is a very important chart. FSH normal, testosterone normal. It could be obstructive, that is post-testicular. High FSH, testosterone low. We saw that that is a primary hypogonadism, that is testicular failure. What you will need in testicular failure is a sperm donation. You need a sperm donation and you can do IUI with that. Low FSH, low testosterone, we just saw. So there is pretesticular at the level of pituitary, so you need gonadotropins. Low FSH and high testosterone anabolic steroids. We just talked about this scenario. So we covered all the important points for the male infertility in just 2 minutes. So that is our motto, success in 70% less study time. So if you want to read in this interesting way, you can choose us and you can always contact us. I've already created a video of 2 months strategy for those who are preparing for Jan 24 exam. So if you have not gone through that video, that's a very important video talking about the strategy. Do go and view that video. That's really going to help you. Thank you so much for your patient listening and your feedback. I would really love to have. Thank you so much.